All right, everybody hear me?
I think it's time to retire.
Well, I kind of feel like one of those, I think when I was probably 5 or 6 years old, my mom had a birthday party for me. Forgot to send out the invitations, so sorry for the low turnout, but we're gonna make a nice, quaint symposium here. We are filming it, so it's gonna go out on will be on our website. I want to thank everybody for coming. The format will stay the same since we're filming it, but again, we'll be a little bit more casual and up close. So we've done a spring symposium in the past, mainly geared towards throwing athletes and track athletes, so we decided this year to expand it. And if y'all don't need me to use this, let me know. In the event, so we're gonna have the first annual fall symposium, and just I kind of want to guess how many of y'all are. There's no athletes here, I guess. They're all still in practice. How many are parents of athletes or grandparents of athletes? All right, then coaches, trainers, a couple of you here. Good. So welcome everybody. Just briefly, who are we? As most of you know, we're a group of 9 orthopedists here and been in Flower Mound since 1976, Flower Mound, Louisville. We've got state-of-the-art imaging, we've got scanners, we've got x-rays, we've got a surgery center upstairs, and state-of-the-art physical therapy. And we're around 24/7. I'm proud to be a part of this group. These guys are brilliant. They take good care of their patients. Dr. Wilkowski's the lone picture there. He just joined us. We haven't had a chance to take a group picture just yet. So as most of you know, orthopedists like acronyms. So we decided instead of trying to say all these syllables, we just shorten it to OAFs. But somebody pointed out to me that there's a definition of a stupid, uncultured, or clumsy person, and that won't really fly because a lot of our colleagues and competitors will have a field day with us. So we decided to call it something else, and we're going to call it the Williamson Orthopedic Associates Fall Symposium. Why the Williamson Orthopedic Symposium is Dr. Williamson founded this group in 1976. He's a local boy, he's trained locally. He's now in emeritus status after over 35 years of practice. He took care of athletes, he participated in marathons, he was an athlete himself, and he still lives local. So welcome everybody to the first annual Williamson Orthopedic Associates Fall Symposium. He's here with us, if y'all can give him a round of applause. Dr. Williamson, we're going to give you a commemorative plaque of the first annual symposium. Another round of applause for Dr. Williamson. All right, so why are we having these symposiums? Pretty simply, to educate athletes, make sure that parents are informed, and create an atmosphere for question and answering. Quick disclaimer, we're not here to offer medical advice or create a doctor-patient relationship. What we're going to do is kind of a brief roadmap. We're going to talk about Pete Ellis and the female triad. We got a great speaker on nutrition, a great speaker on concussion, and really good speakers on knee injuries and prevention. At the end, we've got a lot of professionals that will come up and just take question and answers. I don't suspect we need a lot of breaks, but restrooms are on our left. You all found the water and coffee already. There'll be some door prizes intermittent through the talk. The question and answer will kind of, originally I saw it as having 3 phases. We can text questions up to us. You can write them on the pads in your chair, or you can simply raise your hand. I suspect that with this small audience we can go that route. These ladies can't tell enough how much we thank them for their help. Could have done it without them. So I'm going to start off, and I'll go a little bit more briefly than I planned. I'm going to talk about heat-induced injuries in athletes and the female triad. This is my bio. It's in the literature, or in the handout. This is my team. Tyler, both the Laurens, and Denise. Couldn't do anything without them. They make my practice run. So heat-induced injuries in athletes goes by a lot of different names. There's a whole spectrum of heat injury. We're going to talk a little bit about the spectrum and how to take care of it. Why do we talk about it? It's heat stroke is the third leading cause of death in athletes. Is it important around here? Well, this was just last week or the week before. It is important here. The temperatures are high. There was a player in Northeast Texas that did had a heat stroke and was in the ICU for a while. Just a review of temperature in the body. It's a balance of heat release and heat production. We all kind of know that. Some authors like to liken it to a car and automotive parts. The heat generated is similar to an engine. The harder you run it, the faster you run it, the more heat's going to be produced. The circulatory system is like the cooling system. You got to get the heat to the skin, which is where we release the heat, just like the radiator. So that's production. How do we get rid of it? Well, there's several different ways. There's conductive cooling, convective cooling, there's radiation cooling, and then the most important, I think, is evaporative cooling, which has a big role with humidity. We'll talk a little bit more about that. So if you have a lot of gear on, shoulder pads, you have no breeze and it's humid, you're going to be in trouble if you're in the direct sunlight. Again, just I'll say the same thing over and over. Humidity is a key thing in this area with these fall athletes. The more humid it is, the more trouble you get in. Again, beating a dead horse, evaporation is key and humidity is key. Just briefly, what temperatures are we talking about? Well, we like to be at 98.6 or 37. We get much over 103, 104, we start to get in trouble. This is more the Fahrenheit scale. So the heat illness spectrum, the key thing is 104 degrees is the break point. That's when you start really being in an urgent situation. Briefly, heat syncope, which is kind of the lower end of the spectrum with heat illness, we get depleted. We get dehydrated, we're sweating. Heat cramps, we've all seen the athletes that are rubbing their calves and getting stretched out. So there's debate in the literature. Is it from fatigue? Is it from electrolytes? Regardless of the debate, the consensus is you got to rest, rehydrate, replace electrolytes, and stretch. So heat exhaustion, we're going to talk about heat exhaustion, heat stroke. They're kind of the key things. Heat exhaustion is a protective mechanism, and it's the initial presentation of a more severe presentation. What's the risk factors? The bigger you are, the harder you're working, and where you're working. You don't feel good with heat exhaustion. You're sweating like crazy, and you can't control your temperature. There's lots of debate about some of the specific details, but the bottom line is you don't feel good, you're sweating like crazy. What do? You get them out, you get them cool, you get them elevated, and you get them rehydrated. Pretty simple. The trainers around this area are really well trained, well versed in how to take care of these kids. So when you go back, bottom line is a day or two, depends upon how your symptoms are. So heat stroke is probably what we need to talk a little bit more about. And again, the break point is 104 degrees, 40 degrees if you're the rest of the world. We talked about the extrinsic factors, the humidity, etc. What are the intrinsic factors? Well, there's a whole list of them, but for the teenagers and middle school kids we're talking about, lack of sleep, lack of acclimatization, and some of the medications they take. Everybody in Texas takes antihistamines and has allergies, so we got to worry about that. And a lot of kids like to kind of get up for the games with certain other medications. How can you prevent it? Well, we talk a lot about it, and most of the time you can't control all four of these variables. But if you're wearing pads and helmets, you better be able to stay hydrated or have early days where it's not so hot. Signs and symptoms are bad, they're potentially deadly. Again, the sweating's gone away, all your protective mechanisms have gone away, you're starting to seize or convulse or even worse. So the bottom line is the literature with heat stroke is now supporting rapid cooling. I think that's been around for a while, but they now have scientific literature that if you get them cooled rapidly, it improves survival and long-term sequelae like kidney infection, kidney disease or kidney and liver problems. This is just a couple of slides of how to get them cool, very commonly known in the medical world. So when can they get back to play? That's what everybody asks. Nothing for 7 days, and they got to be reevaluated. Not simply by the coaches, but a physician and lab work has to be done in 1 week. That's consistent in literature, and recovery can take up to a year. Just a summary slide of the similarity and how you can cross over. The thing you don't want to do is end up having heat exhaustion turn into the more deadly heat stroke. All right. So we're going to switch gears and talk about the female athlete triad. Just show of hands, who knows what that female athlete triad is before we start? Anybody know what the triad is? I know quite a few of you do. So good. So this will be, I'll go a little bit more slowly on this. And I think this is really important, and the literature is kind of showing us why. So brief outline, we're going to kind of go over some definitions, talk about some key factors, and then the speaker following me is probably going to be more important than what I'm saying, because she's going to talk about nutrition and how to avoid some of this. So in 1971, there was 300,000 athletes, and everybody remember in 72, Title IX came along, and if you remember, that was when it was mandated for male and female equality in extracurricular activities. So by the year 2010, there's over 3 million female athletes. So it's important to pay attention to. Originally in 1992, when they started looking at the female athletes, they thought it was a one-dimensional issue. Disordered eating, amenorrhea, and osteoporosis. And we'll kind of go over some definitions. It was just a one-dimensional, end of the spectrum thing. Really, it was poorly understood, and we started realizing that it's more serious than that. So in 2007, the literature came out with, it's a three-dimensional thought process, and they recall it energy availability, menstrual function, and bone mineral density, not just the extreme ends that we had before. So again, you want to be here with optimal energy, optimal bone health. The 1992 classification right here, we realized quickly that you've got to be taking care of these young ladies in this area here. So you no longer have to have all three to be considered the triad. It's now more of a spectrum. We all hope our athletes, our female athletes, are in this umbrella here, but we no longer have to wait till the true 1992 definition. We want to start taking care of them if we start finding low mineral density, if we start finding some eating disorders. So it is important. It is out there, so we should pay attention to it. This, as an orthopedist, this is a key slide. If you have three of those components, you have a 1 out of 2 chance of getting a bone stress injury. Your cross-country coaches won't like that if their star runner goes out with a stress reaction. So again, repetition, energy availability, menstrual function, and bone strength. And Christine will talk a lot about energy availability, I'm sure, in the next slide. So I'm not going to spend too much on that. You got to either have good intake or watch your expenditure, or you're going to have decreased energy availability. You can be underweight, which most of us think, hey, that's who's going to get in trouble. But you can be over here and not get good energy availability. We all know what can happen. Parents can look for things in their kids. Again, why are we talking about this? 2 to 4 times risk of increased injury when they suffer from some kind of disordered eating. All right, so again, I'm kind of preparing the way for Christine to talk about her part, but let's briefly talk about menstrual function. We all know regular periods are about every 28 days. Less regular periods are less than 9 a year. And the original definition, 1992, was true amenorrhea, where if these girls were training so hard before they were age 15, they never had a first period. Or if they started training afterwards, they got secondary amenorrhea. Busy slide, just to remind me to tell everybody that we used to think we could treat these issues with taking care of the female reproductive organs. Now we know that it's a brain and combination issue. So it's not oral contraceptives, it's increasing energy availability. Again, Christine will talk more about that. We need it for bone health, immune cells. It's very important for these young athletes, these young female athletes. One other slide, if you have menstrual irregularities, 3 times increased risk of energy. So again, I'm beating a dead horse, but we need good nutrition. So switching gears to the last topic, and I'm almost through. Why are we worried about bone health in these young lady athletes? Well, you get your peak bone mass by age 18 to 20, somewhere in that range. If you don't get it after that, you're going to chase your tail the rest of your life. And the most rapid increase is when these ladies are going through their change and when they're starting to try out for the freshman teams. This is just a quick slide. If you don't get it by here, you're not going to get it, and you'll be having trouble when you get later on in life. So this is crucial, and again, that's why Christina's talk after mine is probably way more important than what I had to say. We all know about steroids, alcohol, and smoking. but there's a lot of other things that all interconnect and play. Nutrition, genetic, hormones we talk about, mechanical factors, overuse, all apply to peak bone mass. You got to live right, you got to eat right to get to where you want to be, or you're going to end up chasing your tail the rest of your life. How do you stop it? Not birth control pills, increasing energy availability. I love this slide. I really can't fit it in, but it's just a combination of repair and reconstruction. So education is key. We're hoping to do that a little bit today. And if you tie both of my subjects together, hydration and energy, which is Christine's going to talk a lot about that next. Probably won't have to do this, but this is a number we'll be texting questions to. We can probably just raise our hands since we're having a quaint discussion. So, Christina, if you would like to come up and give your lecture. Christina's undergrad at TCU, a very great institution. She went to graduate school right up the road and is one of the members of Ben Hogan. She takes care of SMU in Dallas, takes care of Cowboys, and we're really very fortunate to have her here. I really appreciate you coming out. You can see her.
Thank you.
You know how to get your slides up. And just for time purposes, I'll field questions on heat and try it at the end. Christina's got to get back out to practice, so I'll take any questions that you may have on the end.
Okay. So I went ahead and did, we usually do a Fueling the Athlete talk when we deal with our athletes, kind of like a preseason talk almost, where we go over the nutrients that they need and why. That helps them kind of wrap their minds around energy availability. A lot of them we find cut out certain food groups, so letting them know what they need and why they need it for performance. And then a little bit about hydration as well. So I've kind of just cut down our normal preseason talk so you guys can see how we present it to the athletes and maybe give you an idea of how to talk to them about it as well. So sports nutrition basics, we'll start out with fueling frequently is one of the biggest issues that we have. A lot of them will eat once or twice a day and they expect that to fuel them throughout the whole day. So we really preach on the fueling frequently, every few hours, and more so for keeping mood and energy up rather than anything else. So a lot of them will say, oh yeah, that'll help my metabolism go faster, or that'll help this or that, but the main thing is mood, focus, energy levels, especially when they're in class and then transitioning to practice too. The 80-20 rule is that we talk about following eating for health 80% of the time, or eating for sports performance, and then 20% of the time is kind of like your free meal or your cheat meals, to where you still have things that you really enjoy but you know they're not as good for you, and we place those not around a workout or a competition. So the three main nutrients that we talk to them about: carbohydrates, proteins, and then our fats. So starting with carbohydrates, these probably get the bad reputation as far as when new trendy diets come out. A lot of times carbohydrates are cut out of those. So it's really important for us to let them know that that is what their body uses for energy. That's what's stored in the muscle as glycogen. And so we go over this quite a bit. A lot of them have the idea that when we say eat carbohydrates, they think bread and pasta. Their mind doesn't really go past that to all the different kinds. So we have up here, we have simple and complex carbohydrates. The simple ones are the ones that they usually eat a lot of, that we don't want them to eat as much of. So candy, juice, soda, a lot of like convenient snacks, crackers, things out of a vending machine. We want them to go more towards complex carbohydrates throughout the day. So when we're going for like bread, rice, pasta, also choosing the whole grain version of that. So that gets them more fiber, vitamins, minerals. It sticks with them longer, so again, balanced energy levels throughout the day. Then fruits and vegetables are up here. Those are also carbohydrates. So people tend to put those in their own category, but we remind them, especially when we're talking about their plate being half carbohydrate, that does include also fruits and vegetables on there. Dairy has carbohydrate, and then sometimes if they're using the sports drinks, the gels, the dews, those are all carbohydrate as well. Things out of a vending machine. We want them to go more towards complex carbohydrates throughout the day. So when we're going for like bread, rice, pasta, also choosing the whole grain version of that. So that gets them more fiber, vitamins, minerals. It sticks with them longer, so again, balanced energy levels throughout the day. Then fruits and vegetables are up here. Those are also carbohydrates. So people tend to put those in their own category, but we remind them, especially when we're talking about their plate being half carbohydrate, that does include also fruits and vegetables on there. Dairy has carbohydrate, and then sometimes if they're using the sports drinks, the gels, the goos, those are all carbohydrate as well. So again, we tell them to focus on the grains for the complex carbohydrates. Those are higher in the B vitamins, those are higher in fiber, and they stick with them longer. Best choices would be your whole grain or whole wheat choices, so those are listed up here. Then protein, many athletes will immediately think of muscles when they think of protein, which is true, but also it's very important for the immune system. So a lot of times, especially with female athletes, we have them skipping out on protein, and we need to remind them that they also need protein. Protein does not make you big and bulky, but helps you recover, helps your muscle tears recover. So these are all forms of protein here. And most people know these, and then when you get to the bottom, some of them will want to use like a whey protein supplement. Vegetarians you might have a little bit harder time with, but nuts, seeds, peanut butter have some protein, and then you have to work with them on finding other sources of that too. And then fats. So 2 categories of fats. We have our saturated, which are more of like the fats we want to avoid. A lot of fried foods, packaged foods, creamy sauces. And then we have the unsaturated, or those high in omega-3, which would be our good fats. So looking at different nuts and nut butters, cooking with olive oil, canola oil, avocado, flaxseed, and then fatty fish like salmon. Those would all be the best choices. As far as fats, we do like to remind them that that helps to get inflammation out of the body. So a lot of post-workout meals end up being like Chick-fil-A, Taco Bell, a lot of these things that are very high in fried foods and bad fats. So helping them realize that, and I'll talk about this more in a second, in that post-workout window, when you take in those bad fats or fried foods, you're actually just stalling recovery and keeping yourself in a state of inflammation, and that helps them to start changing how they think about it. So these are just examples of putting these 3 main nutrients together, and we won't go over all of them, but just like the first one up here, a lot of kids in the morning grab a bagel or toast or something on the way to school. If we're going to make it like a complete breakfast, we would have the whole wheat bagel up there for carbohydrate, the peanut butter would add healthy fat and protein, banana is their fruit, carbohydrate, and the 2% milk then adds in more protein as well. So that's how you take just like a grab-and-go bagel, and then you make it into a complete meal. So all of these would be examples, good examples of a complete breakfast, but still quick and on the go. And then same thing here with the snacks. So instead of just grabbing a bag of goldfish, chips, soda, candy, these things combine protein and carbohydrate together, so it keeps their energy levels and everything up much longer than just a quick carbohydrate snack would. So as far as hydration goes, this is hydration recommendations around a workout, but I do also always tell them that if they're thinking about their own personal hydration, we go off of their body weight. So if they weigh 150 pounds, we're going for ½ ounce to 1 ounce of their weight over the course of the day for optimal hydration. So a lot of them try to drink just before and just after practice as far as water goes, and then they might go back to soda, juice, something else. And some of those things are okay, but we want them to focus on water, good fluids. They can do unsweet tea, Propel, G2, that kind of stuff. But we want them to make sure they're getting in enough and not just drinking those things right before and right after they work out. So pre-exercise, depending on how much time they have, 2 to 3 hours before, it's around 20 ounces, maybe up to 32 ounces. But if there's only 10 or 15 minutes before, we obviously don't want them chugging a bunch of water right before they go practice, so then we take it to 5 to 10 ounces. And then the way we explain that would be a swallow or a gulp would be 1 ounce. So that way in their head they kind of know what that means, because they're not going to pay attention to how many ounces. During exercise, if every 15 to 20 minutes they do get a break, then it's the same amount there, 5 to 10 ounces. That just helps to start replacing the sweat that they're losing. If they are working out outside or over an hour, that's when the sports drinks come into play, and that's when they become very helpful. And then post-exercise, if you weigh the athletes before and after workout, Every pound lost needs to be replaced with 16 to 24 ounces of water prior to the next practice. So again, it doesn't have to be immediately right after if they lost 5 pounds. It just needs to be over a course of time and must be before the next time they go out. So if it's practicing once a day, much easier than if it's a 2 a day where you have to be a little bit more strict. As far as cramping goes, again, fatigue or could be due to electrolytes. So these are 2 different categories of foods to where they can get the electrolytes in throughout the day. If you're dealing with 2-a-days or very hot outside, obviously we have the products like Gatorlytes or the electrolyte tablets. Some people are afraid of those, but as an athlete in sports nutrition, salt and sodium is important for the athlete to put back in. I have a lot of athletes that do cramp up, but we've been taught as a whole not to salt our food. But for an athlete, we have to let them know that that is okay if they're dealing with cramps and other things because they lose so much salt when they sweat. So in like the typical Gatorlyte package, there's around 800 milligrams of sodium. That's probably how much they sweat out within an hour, especially if they're wearing like their football pads and all that stuff too. So these are different forms of food they can get it in, obviously salting their food, then the different potassium foods. So it's in a lot of fruits and vegetables. And then at the bottom we have like our sports drinks, the electrolyte tablets, those are always helpful as well. And then post-workout nutrition, which is probably the thing they can implement the easiest and would help them the most. The 2-hour window after they're done exercising, we want to replenish carbohydrate or the glycogen that's stored in the muscle, repair the muscle or the little tears that have been made in it, and then make sure that they're rehydrating. So they have 2 hours to do this to where the muscles are more sensitive than they are any other time of the day. So this is where we usually focus on good nutrition choices, choosing those carbohydrates, your protein, those healthy fats, making sure that in that 2-hour window it's the best choice that they can make and it's not Chick-fil-A or a fast food place. If they only have 45 minutes or so, if 45 minutes or so has passed and they've had a small snack, that's the best option than go getting a big meal later. But if they have to wait the 2 hours, that's okay. It's just that we normally try to get them to do like a post-workout snack or shake and then a bigger meal later if it's going to be 2 or 3 hours until they get to that meal. So again, carbohydrate, that's what's used to replenish the fuel in the muscle, and then protein helping to rebuild. And the protein recommendations are between 20 and 40 grams of protein post-workout, depending on the size of the athlete. So usually a lot of products are geared towards that 20 gram level, or you can easily get 20 grams with like low-fat chocolate milk. The 2% string cheese have like 8 grams in each stick, so 2 of those with a piece of fruit. It can be very simple and easy until they get to like an actual meal. And here are some more examples. So there's some different shakes that can be used, some ones that are already pre-made if they like those. Low-fat chocolate milk is really popular, especially in schools. A bar and milk, or like a Greek yogurt and fruit, Greek yogurt and granola, all of those things would be good options. And then the last thing I wanted to touch on is supplements, just because so many of them are using supplements. Most supplements are not regulated, which most of us probably know this. A lot of them go to GNC, Vitamin Shop. So these are 2 different websites that are third-party companies that actually go in and look at supplements. So they take a batch of supplements that have been made and test them. And if you go to like NSF Sport, it'll have a whole list of things that are approved. It only has things that are approved on there. So that's very helpful for them. I constantly get questions like, so what do you think about C4? What do you think about this? What do you think about this? And they just have no idea how supplements work. So the third-party company goes in and tests for quality and for safety. So a couple years ago they did tests on whey proteins, and 2/3 of the whey proteins failed the test for one of those. So quality would be on the label, it has 20 grams of protein in a scoop, and then it comes back. They test it comes back, and there was only 5 or 10. And then safety would be that it comes back and it's been lined with something, it has a banned substance in it, something like that. A lot of companies make multiple, like they'll make pre-workouts, whey proteins, gainers, and those things can get mixed around and nobody really regulates what's going on with those. So just making sure if they do want to take a supplement that they get it checked first, especially if they are going to be playing sports for a while, they may as well start with a good supplement right now. And then making sure that they know that, the ones that are on here usually are the ones that are backed up by research, but whey protein, creatine, using electrolytes, there's really not that many supplements that are proven to be effective in the first place. So just helping educate them on that. The things that are listed are things that have come up that do help you or cause you to test positive for positive drug tests, especially that geranium root oil. Most people would look at that and they think that's, like an herb or a healthy oil or something. And then the last thing on here is energy drinks. So the only energy drink that's on one of these websites is Red Bull. That's the only company that pays to get their drinks tested. So again, Monster, other companies could say 200 milligrams of caffeine on the label, but it could have 400, or it could be, it could have other substances in there. So just be really careful with energy drinks as well, because those are really popular right now too. Yeah, so that's the end of my slides. I just wanted to give you guys a basic, kind of presentation on sports nutrition and how we approach them getting in enough of their carbohydrate, protein, and healthy fats, the hydration, and then the supplements too, of course. And I can take any questions that you guys have.
Anybody have any questions? I have one. During your competition, football game, for example, what do you prefer during the game after you've reached the window? You need to be having we use Pedialyte, Argyle,
Mm-hmm.
Gatorade, Powerade. What do you have a choice with that or a preference?
Yeah, we collegiate-wise, we don't have a preference at SMU because we're a Powerade school. But we do use the Gatorlights just because we have to use Powerade in the bottle, but we can use little Gatorlights to mix. As far as camp has gone, we've done Gatorlights twice a day because it's so hot outside, and we weigh them before and after. So we're weighing them before they go to practice. After they go to practice, most of them lose between 5 to 7 pounds during practice. And then they are taking their Gatorlights, they're going to lunch or dinner, and we're weighing them out after their meal as well. And they are not leaving their meal until they're within 1 or 2 pounds of their weight. And that's because we're in two-a-days. So with game day, night before, we will be giving them like a Gatorlight high electrolyte drink. Then the morning of, they'll probably go with Powerade, their meal, and they'll have their game. And then depending on, we haven't had any issues with cramping after the first day of camp, which I think is in part due to we've been extremely strict with the hydration, the weighing, and all the Gatorlights. So as long as we don't have issues with cramping, during games, we'll stick with the regimen of high electrolytes night before with the pregame meal, and then day of, it'll be Powerade. They always have the option to take Gatorlights if they want them. And then they'll have breakfast and pregame stuff.
How long have you been employing the technique of weighing before, all the specific weighing techniques for several years or just?
Well, previously before working with Ben Hogan and being at SMU, I was with Special Forces Military in North Carolina, and we did do it there as well. And their workouts were actually very similar to professional athletes because they are wearing all their gear. And then they're going out for like 4 or 5 hour electrolytes. And then before that, I worked with NFL combine players. So again, it's probably been 5 or 6 years that I've been doing that.
And as you do it at SMU, are you seeing, do you have any recollection of what it was like before? The number of cramping and injuries and pulls, and you're seeing a large difference afterwards since you've been doing this strategy?
That's a good point this year. So I will have to ask about that. I did get a lot of questions from the athletic trainers on why we were using so many Gatorlights this year, and a lot of pushback about that. So again, I think people just, when they think about high sodium and high electrolytes, they think it's bad for us. But then the sports nutrition mindset has to go to, well, they're wearing pads and they're outside and it's 100 degrees, and kind of just education all around. So I know this year we had cramps the first 2 days, and that's when we upped the Gatorlights to 2 to 3 times a day, depending on the player, and then we haven't had them since. And again, they're outside for 2 to 3 hours a day, so that would be, in my mind, a package of Gator Lights replaces an hour of them being outside. And I would have to ask about last year. I don't really know about that.
Other questions? One last question I have is, in your evening game kickoffs, what is your ideal game day meal plan? For example, a lot of high schools, they play at 7:30, which would be similar here, y'all's 6 or 7 o'clock kickoff. What do you like to eat for breakfast, not eat for lunch, that kind of stuff?
Yeah, we typically will plan it out to where, so if we have a training table set up earlier, so breakfast and lunch are going to be much more flexible as far as like some heavier foods, and same thing with night before dinner. So we'll have, let's say breakfast, we have oatmeal, we also might like have waffles, pancakes, we have multiple choices of carbohydrate. We have eggs, an omelet station, healthy fats might be something like avocado with their omelet, and then we always have fresh fruit. We have peanut butter and stuff like that to put on the toast or English muffins. Breakfast is a pretty big meal. Then lunch, we might go to something more like sandwiches. We've done like fajitas. It's a little bit more simple. Then their dinner is usually early. So if there's like a 7 o'clock kickoff, they're eating dinner at like 4 or 4:30. And then if someone wanted something before, it's going to be just all carbohydrate, like a piece of fruit. We have the Prime pouches that Gatorade uses, the Chews, Powerade, but most of them won't want to eat anything within an hour of the game anyway because they don't want anything heavy sitting in their stomach. And then halftime, again, same thing that would be the 30 minutes to an hour before. It'll be salty carbohydrate snacks like peanut butter crackers, maybe trail mix, Chews, different bars that we have. We have Gatorade bars, some of the Kind bars, as long as they're not high in fiber. Trying to think, Nutri-Grain bars. We do an assortment, and then we try to change it up each time just so they don't get bored of and feel like, oh, like it's time to eat again, I don't want to eat again. So during camp, that's been a big issue too, is making sure that it's new things each time. Okay, well, I also left some of my cards, I think up at the front. If you do think of any questions or want copies of the slides, then I'm happy to send that to y'all too.
And Christina's cards are at the front desk there. See if I can get these slides here. We'll, All right, next speaker, she's nationally and actually internationally known neurologist, epileptologist, and is now going to talk to us about traumatic brain injury, Deborah Cantrell.
Is this on? Yes. Okay. All right. Well, today I was asked to speak about concussion. And right from the beginning, I want to make sure that we understand. Over the decades, it's been, I got my bell rung, I got a little woozy, but people, it is a traumatic brain injury. This is definitely injury to the brain. Now, this slide actually, as of this morning, I'm sorry, it should have been updated, but we've now had over 4 million, we're approaching 5 million reports annually in the United States alone of concussions. And at least these have been, but we're now reporting now over 6 million traumatic brain injuries a year, and of those, 75% are the concussions. In 15 to 25% of these individuals, their symptoms will last over a year, and so disability is highly. It is when we're dealing with the school-age kids, then you've got to know about their education and things like that. So you can have not only physical, psychosocial, you can have far-reaching consequences. Now, the definition of a concussion, it certainly is a very complex subject. It's a pathophysiological response of these biomechanical forces that get imparted to the brain, and then that sets off an entire dysfunction of the network of the brain's functioning, and you get a constellation, sometimes, of symptoms that reflect more of a functional rather than a structural problem. What do I mean by that? Well, it's more the functioning of the brain that you can see most of the time, thank goodness, in these injuries. For instance, you get a CAT scan or an MRI, a picture of the structure of the brain, you may not see any evidence of any injury. This is at a microscopic subcellular level at the brain cell level. So it's more functional than it is structural. The Centers, just to kind of get this message out, the Centers of Disease Control has now classified this as a major issue of health. And in addition, that it's a silent epidemic. Why is it a silent epidemic? Because we're not recognizing it, because it's not getting reported. And then, when's the last time you thought about pre-K individuals? We now have in pre-K, we have year-round sports, and who's going to know if they're concussed or not? Plus, we're playing in Wally Mart helmets. So let's talk about these biomechanical forces. The biomechanical forces, they can be rotational in nature. They can be linear, either acceleratory or deceleration, or they can be a combination of all of the above. And when these get imparted to the brain, it sets off this neurometabolic cascade. The chemicals that we actually function by, the neurotransmitters of our brain, there's a total impairment of those. Some of them, called glutamate and aspartate, they're actually excitatory chemicals, but now that they've been forced out of the nerve cells, they're actually toxic to the brain. There's huge shifts in the fluid and the ions in and out of the nerve cells, which should not occur. The actual metabolism of the brain is off, and a lot of times even the sugar metabolism is off. A crisis of the brain. We have the brain cells called the axons. You can actually, in a concussion, stretch those, or there are shearing effects. So start thinking about the children, the athletes, they're still developing brains, and now you're shearing their axons. So those developmental and learning pathways are now abruptly impaired. And we've also, in these athletes, noted decreased blood flow of the brain. Now, let me make sure we understand this. This is an important part. To obtain this minor traumatic brain injury, better known as the concussion, the brain itself does not have to contact the skull, nor does an object need to contact the head. In other words, for these major blows to the body, it induces this jarring effect of the neck and the head, okay? And that alone can cause these shearing effects. So think about the repeated blows in some of our athletes that we see, or the shaken baby syndrome, that kind of thing. So keep those things in mind. So there is today no objective test that we can do to diagnose or treat this physiological state. There's a subset, which we'll keep going over, and this is the scary part. Not all of these people that have had a concussion will present with any symptoms, okay? But we're going to see why here in just a minute. It's so important. We've got to start suspecting. But so we can't rely, it's dependent on the pathology to the brain. It's also in that particular brain, is it going to produce a symptom or it's not going to produce a symptom. So you have to take every individual as an individual case. Now, because we've highlighted over the last few years concussion, what it can do, we'll go into the second impact syndrome, the CTE or the chronic traumatic encephalopathy you've heard about inducing in our athletes and at the professional level. We now have legislation in all 50 states that it is mandatory for education for our athletes, our parents, and our coaches that there is now in every state a law that if you suspect a concussion, much less you've diagnosed it, that player or person must be removed from practice or play. And then they are not to return to play until they have been evaluated and cleared by a medical professional. Now, people ask this all the time, so who's at greater risk, okay? Age has a lot to do with it. And if you're of a younger age, you're more likely to get a concussion. It may be because the brain is still in its developmental style. It may be that our necks aren't as strong. There's several factors that can play into it. Females tend to be more prone than males. If you're at a higher level sport, collegiate, for instance, versus your high school versus your middle school, in that order, they're more likely at a higher level. Competition, meaning they're in a real game, or say a state championship versus their regular practice. Prior concussions, big factor. If you've had a prior concussion, much less multiple, you're much more likely to have a subsequent one. Body checking in hockey is highly rated, but we can put that out to other sports, whether it be the spearing in football, the head checks, the inner body connection with the heads in soccer. Those are it. When I get asked what sports are more likely for it to occur, in males, football, ice hockey, lacrosse, soccer, wrestling, and basketball. But again, remember these things are underreported. So there's many of our sports that go underreported or non-reporting, such as boxing, etc., and then your new power sports where they put them in the cage and the main game is the blows to the body and to the head. Female athletes, similarly, soccer, ice hockey, lacrosse, basketball, softball, and gymnastics. I don't want to get myself in trouble with my gymnastics, but we've also got to include the cheerleaders. That is an athletic sport, and it's highly competitive. I noticed, and as far as volleyball wasn't listed, but I will tell you that 2 years running, a lot of my athletes, the most I've had was from volleyball players. So that's a little underthink, but you take one of our D3 spikers, that ball is coming at your head at about 60 miles an hour. Concussion 1 is when it hits your head. Concussion 2 is when your head bounces off that floor, and then you probably got a contracture when the brain sloshes forward. So again, there's many of these sports we don't think about as being contact sports. So again, it's very important. Signs and symptoms. Okay, you're looking now, you think they've had them, who's going to have any kind of symptoms? Some of them will not. Some of them will not have an initial symptom. Some of them will evolve over a matter of hours. So this is why they have to be observed. There are some of them that even over that several hours won't have a symptom, but only when they try to return to their daily living will they start getting symptoms. So again, no reliable objective test to tell us right then and there who has or hasn't. It's a clinical diagnosis. It's one based on good old-fashioned examination, history, and keep looking at the patient. Now, so if you even suspect a concussion, it is mandatory that you remove them from play or practice immediately, and they should not be allowed to return. Then it's involved serial neurological examinations, and we hope through removing them from play, we're keeping them from getting not only another injury, but a more severe injury of that current injury. Now, when you know for sure, who do you not return to play? I cannot emphasize enough, I'll get into the second impact, even if you suspect it. But certainly if they've had any loss of consciousness, remove them. If they've had any prior concussions, especially in that season, if their symptoms have now lasted over 15 minutes, if you let them walk up and down, for instance, the sideline, and now they've got that headache, etc., don't let them go back. If they've had any amnesia for the event, amnesia for what they had for dinner, amnesia now of what was the play, or the post-concussion syndrome itself. So, who's at greatest risk to repeat a concussion now that you've diagnosed one? It's in that first 7 days. And in that first 7 to 10 days, that's when that neurometabolic crisis is going on in the brain. It's been hurt, it's injured. So short-term risk, athletes, these individuals suffered impairment of attention and concentration, imbalance, impaired reaction time, and diminished higher cognitive processing. So when you've got all of that going on, yeah, let's send them back out there into the field of play. Okay? Not a good idea. Long-term risk. Those who even prior to the injury may have suffered from things like inattention, impulsivity, hyperactivity, poor neck strength, certain playing styles. And then there are possible genetic factors. Those aren't well known, but there are some. So I keep mentioning the second impact. And this really started getting people's attention. Let me talk to you about that. So when you have a concussion, but you have not let the brain heal, and now you get another one, and let me emphasize this, I'm not talking a blow, I'm talking a thump. A potential thump to the head or a jarring of the brain. When that happens, it can induce a second impact syndrome. And when it occurs, despite intensive medical assessment and care, 50% of these people will die. Now, it also occurs when it's known and when it's not known. It's also recognized after they've had significant trauma. Okay? Maybe it's an orthopedic injury, a hip fracture, hip displacement, or they've had to undergo an operation. It can occur after that. What happens is it's a rapid onset of swelling of the brain. There is increased pressure around and in the brain to the point that it strangulates the portion of the brain that controls your heart, lungs, blood pressure, and pulse. And despite intubation, despite controlling your heart, it is a total collapse of your physical structure. And again, there's a 50% mortality rate. And then as far as what morbidity, meaning what you're left with if you've survived, we don't know. So, my take-home message would be, if you suspect it or you're still in doubt, when in doubt, sit it out and think again. Okay? It's not worth the risk of sending them back. So, let's do, for those who are going to present with some symptoms, what are they? Some of them, they're dazed. Some of them are confused. They tend to repeat themselves. They just seem out of it. They'll answer questions slowly. The amnesia, the loss of consciousness. Most people around here will tell me, well, they didn't have a concussion because they didn't pass out. Well, 10% or less will pass out. So that's not that. They may have personality changes, sleep changes. They are going to complain of potential headaches, nausea, vomiting, dizziness, overly tired, visual problems. They don't like bright light. They don't like loud noise. And their reaction times are decreased. So remember that when you're thinking about sending them back out there, because now they can't react. Plus, we'll get into the processing speed of their brain is terrible. So they can't take in information and they can't react. Concentration's down. They can't think clearly. Remembering is a problem. Emotionally, they're irritable. Some of them are sad. Some of them are nervous, and some of them just have heightened emotions. I know, I hear you out there. They're already that way. But maybe it's a little worse than usual. All right. So I think, and especially Orthopedic Associates for decades has done a good job with the next one. I think it's key that they have pre-injury assessments. So when you see these guys and we go out to the schools and we do these pre-physicals, it's so important. It's so important because that gives us an opportunity to assess even if that athlete or that individual should play. It gives us a chance to do a good physical exam and document it. Review their past medical history. What's their family history? Do they have a history of prior brain injury and or concussion? And then I think it's key that we do a good neuro exam and history and family history. Now, there's also this baseline testing, okay? It's very controversial sometime in the literature if it's good or not. Personally, I think it's very good because these tools may not be perfect in helping us diagnose or manage, but they sure to heck help you document what was this person like before it happened, okay? So I listed some of the more standard ones. I'll draw your attention to number 3, the immediate post-concussion assessment or cognitive testing. Y'all know it as the IMPACT test. It's very good. They do it on a computer, but you get at least a standardized assessment. And most of the schools around here are using this. Myself, Dr. John Gomez, and Dr. Bruce Linden, we have opened up the Sports Concussion Treatment Center here in Highland Village on 407. And we're also instituting C3 Logics. And we've gone out to pretty much most of the schools in Denton County and done their baselines. C3 Logics can be done on an iPad. I can have it on the sidelines. We interact with our trainers at the various schools, but it also gives us a chance for the athlete to interact with us, whether they're concussed or not, but the baselines are helpful, balance issues, memory, and things like that. But I think, again, the tests are very helpful. However, no test is going to help us diagnose or manage, but it does give us additional assistance. But basically, the final diagnosis as well as management rest on good clinical history and serial examinations, and it's a clinical diagnosis. So, again, what's our initial management? We've gone over that. We remove them from play so they don't re-injure themselves. We relocate them to a very safe and calm environment if possible, and then we start performing these concussion evaluations. Once we make that diagnosis, the patient should not return to participate during that 24-hour period. Once they're removed, try to make them comfortable in a distraction-free environment. They should remain under direct observation for at least a minimum of 4 hours. Don't give them any of the over-the-counter anti-inflammatories except maybe Tylenol, because that increases their risk of brain bleed. And I wouldn't give them any pain medications or narcotics, because when you're trying to assess what is their amount of sedation, how are they with it, then this only complicates the factors. As we've heard before, it's imperative for you to keep them hydrated. The nutrition, they need now acute rest, both cognitively, mentally, and physically. Okay, so you want to put them down. We don't want to put them in a coma, but we want them to be at rest. Don't leave them alone for 24 hours. That's where you'll hear, wake them up every 2 hours, check their pupils, things of that nature. And you got to tell them not to drive, okay? So we're out at an out-of-town game. Our car's at the field house. Now, okay, well, we'll get them there and then we'll let them drive home. Not a good idea. Sleep, and you need to emphasize sleep hygiene. When I get asked, so who are you going to send to the emergency room? Who's going to get an emergency CAT scan? Okay? One of the things, this is what the parameters are as far as the Academy of Neurology. As usual, I agree with some and I disagree with others. But one of the ones they don't list is any loss of consciousness. If there's any loss of consciousness, I think they need a CAT scan. I think they need to go to the ER. Okay? Because an epidural hematoma, they'll have a period of loss of consciousness, and then they'll be fine. And then by the time you find out that they've got a large expanding arterial bleed, they're dead. So, but you want, if you can't observe them for that 4 hours, send them on. If their last glaucoma scale is less than 15, send them on. If their cognitive status is deteriorating or they just keep getting worse, any spinal injuries, any new symptoms, and if it's the family's preference. Now, let's talk about phases of management. There's 3 of those. We've talked a little bit about one. It's that acute rest phase. Okay, this usually lasts anywhere from 2 to 7 days in a typical case. But each one of these phases that I go through, you have to individualize it. Okay, so it's based on their symptoms, symptom tolerance, and how we induce that. So some are younger. If they're younger, it's going to be probably longer potentially. And if they have any comorbid pre-existing conditions, it may be longer. That acute rest phase is sometimes called the cocoon phase. I call it my poop, pee, eat, and sleep phase. That's basically what I want them to do, is eat, poop, pee, and sleep. No cell phones, no computers, no bright lights, not a lot of activity, but you want them to rest, okay? Now, then hopefully they're going to gradually get better, all right? Now when they think they may still, but In this phase 1, these symptoms and signs are so overwhelming, they can't do their daily life. They can't do school. They don't want to get up because they feel bad. Now we go to phase 2 where maybe they have still some symptoms, okay, but they're able to do their daily living. So this is when you need to definitely progress them to the return to learn, okay? It's very important. If they're still school age, we get them back in school, but we're also testing them with the increase of concentration and attention. Are they going to have increased symptoms? And so that, and then the last phase we'll go over will be the graduated exertion. That one should be instituted once they're entirely symptom-free. Phase 2, if you've got them on any medication or their doctor, that should be where you start weaning them off, and phase 3 should not occur until they're completely off any medications that might mask the symptoms. So, risk factors for who's going to have a more prolonged recovery, all right? If they have a prior concussion, they're probably going to have a longer time. Again, that younger age, if they've had headaches prior to the injury, and that was one of their main symptoms, increasing their exertion to see if we can spike the symptoms to come back, okay? To see what their level of tolerance is. Now, at each one of these stages, if a symptom comes back, you stop it immediately. Then you don't do it for another 24 hours. Then you go back to the previous step and see how they fly. All right? So the first one would be the light aerobic exercise, like a stationary bike, 20, 30 minutes maybe. Sport-specific aerobic exercise, the next step would add the gait and the balance, movement. The next would be the non-contact training drills, which adds that cognition and agility to it. And then if they've had no symptoms, they're not on medication, they're doing well, then we put them, after medically cleared by a physician, then they return to a contact drill. If they pass that, then they're returned to play. Usually, minimally, this is going to take about 6 to 7 days to complete. All right. So I was definitely asked to comment on prevention. I think programs such as this, and again, thank you to Orthopedic Associates for having programs like this, because I think increasing the public's awareness, our players, our school staff, through educational processes like this, hopefully we at least get the definition out there, what to watch for, and hopefully we can make more accurate diagnosis and treatment. Again, the age of participation, y'all know it's in the media. Should we be, how many repetitive concussive disorders are occurring before we know? Is there a point to having these players at an early age, less than 12, do this? We have to, if we're going to have rules and regulations, we better sure enforce them. And there better be stiff penalties. Avoid, we need to make it where the head and above the shoulders is not the point of contact. We don't need that to have a good game and competition, okay? Because the oohs and the ahs in the stands, when it's a great hit or something, when it's your kid or when it's your loved one, it's not such a good ooh and an ah. We need to also ban any targeting. Again, these return to play regulations, we need to enforce them. And again, appropriate technique. Our coaches teaching them how to play the game and how to do it well. If you're going to have protective gear, let's talk about these helmets. There is no helmet on the planet that is concussive free, okay? The helmets were made to avoid severe brain injuries as well as skull fractures. But if we're going to use them and those techniques, let's use them right. And that's probably another time. I'm over my time, I think, as well, on how to do that. Parental involvement is key and support. Neck strengthening is controversial, but I think it's key because it keeps that torque of the head going back and forth. If they're in a sport such as football, I'm big on those heavy neck rolls because that keeps the torque from going back and forth. And depending on their position, what I call the vampire collar or the cowboy collar, that really cuts on that neck play going back and forth. Mouth guards are also controversial. It's really good for the dentist and the dental. But on the other hand, the cribriform plate is a piece of like honeycomb bone right here, and right above it's the brain. So it does, in my opinion, absorb some of the force on the mouth guards, preventing that pressure going directly up to the brain. Again, we've heard earlier, very well put, proper nutrition and hydration is key. We've got to change our culture, okay? If we want to play in a gladiator stadium, let's call it for what it is. If that's not our point, then let's get this to where we can have competitive games, but it's not to take people out. And again, no athlete or person should be participating if they're alcohol or drug impaired. So I get asked, who should we tell you shouldn't play ever again? We should retire them. Well, if you're noting that a little amount of force is causing an injury, that's a reason. So a lowering of the threshold. Those people who now, when they get a potential concussion, the symptoms last a long time and they're severe. They should be retired. Or they're showing deteriorating brain function without an injury or even with minor play. They should be retired. So I hope we know this is a very complex issue and it has great ramifications. But I think we not only need to consider these risks and consequences of a brain injury, but we sure need to understand and appreciate that there are great benefits to participating in athletics. Thank you very much. Do you want to take questions?
Sure. Y'all want to stand out and stretch while we're asking questions? Anybody have any questions about concussion?
I've got one, Dr. Cantrell. Obviously, you're specialized in recognizing their ability to return to sport. We talked about how they need to get medical clearance. Is it very challenging as a neurologist for some of these kids getting cleared by their family care, primary care doctors who may not have as much of an awareness about the situation?
We have a great group, I think, in family practice, internal medicine here, as well as our orthopedics. I think it is difficult because a lot of times it's how they present. I try to make myself very convenient for people to come. That's one reason we did the sports concussion clinic. Dr. John Gomez is an emergency room doctor, and Bruce Linden is a family practice doctor. So it does make it difficult. Sometimes I'll see the more difficult cases, meaning they're still having symptoms after 3 weeks or months. But I also am one of the team physicians for Argyle High School. So unlike when Jeff and I went to Harvard, some of those doctors have never seen an immediate case. So I think looking at these people, being able to do a complete neurological examination and assessment is key. And to your point, I have very esteemed colleagues, but some of them aren't as versed as looking out for the little abnormalities. Or knowing about head injuries, knowing that they look fine, but I really suspect that they're not fine. Did that answer your question? Thank you. Yes, sir?
I was just thinking that it would be fantastic if there was a procedure where our coaches are people connected with our young athletes are almost in a mandatory situation where they get the type of training that you just gave to us, but even more pointed to their needs.
There is legislation now that the coaches are mandated to attend classes, and also it may not be physical exams, but they have to be educated on concussions and minor traumatic brain injuries. And that's in all 50 states. Thank you. Anybody else? Okay, thank you so much. Oh,
Sorry. Yeah, I feel like 10, 15 years ago in residency or training, it was like you needed a camp to, and it'd be like, oh, after a couple of weeks, it was very arbitrary. And then all this stuff came in the NFL, obviously, and I feel like, I think if it's my kid, I want to be overprotective, but I feel like it's gotten really, just as a physician, and we're very, very sensitive now, right? And I don't know if at some point there'll be something more objective that will come. Maybe there is. It's so complex, the brain, that you can't come up with an objective measurement. I think
we don't have.
Exactly. And like if you could CT scan someone and say, oh, their concussion scale is 5, we'll probably never get to that point. But I was watching something on ESPN the other day on some kid who got Lou Gehrig or something. They felt like he's a soccer player.
Right.
And all the headers they do, we don't concuss them every time they head the ball.
Right.
But in essence, they're getting a concussion every time.
Correct.
Especially those kids. So I guess at what level are we going to start analyzing those kids as soccer players and say, hey, we're going to stop heading the ball, because I do think those kids are probably suffering something. So what do you think about, like, say, a soccer player? We don't really concussion soccer players, but every time they're heading the ball at that high speed, those and taking their neck and whipping the ball. I think
Well, we actually do if they present, as you very well know, with signs and symptoms. But I think you bring up an extremely good point that I can only gloss over. Again, soccer, for instance, as you know, we're now starting year-round leagues in pre-K. As well as things such as football and things like that. So again, when he's talking about CTE, chronic traumatic encephalopathy, that you've heard about in football players, well, and again, for me, for Dr. Singhal, when we asked, have you ever had a concussion? How many of those did you have when you were 5 and 6 and you didn't even know about it? Okay, this repetitive blows to the head, okay? So it can add up and it can have, as Dr. Singhal very puts, it can have long-term reaching consequences. So I don't know in our lifetime if we're actually going to have a test that you send them through a machine and it tells you if they have or not. But I think whether we're their parent or we're their physician or we're sitting up in the sidelines, again, even if you think that was a blow big enough or you think it's enough, then, or they even have a minor, I just don't feel well, then again, I can't emphasize enough, take them out. It's for the greater good. I think you brought up a good point. Thanks so much. Anything else? All right. Thank you so much for your time and
All right, Dr. Singhal, probably one of the smartest guys I know, going to talk about knee injuries from a layman standpoint. I think I'm going to try to pull yours up here.
Can everybody hear me? I talk notoriously loud anyways. Known to be in one clinic and the other clinic can hear me, so if I talk in the mic, I might just hurt everybody's ears. I would like to really thank Dr. Cantrell and Cheryl and everybody for spending the time to put this together. I know he feels like it's a birthday party that no one showed up to, but it's a great idea, and I think this is the first one. So I think when even the few people here will talk about it, it's going to only get better. But I do think this is a community service that we're doing, and I think it is good to make people aware. Can people hear me? Or should I use the mic?
You should do the mic.
Do the mic.
See if you're recording right.
Hello?
Better.
All right. Sorry, I'm trying to get this. The one thing this didn't allow me to do is use the PowerPoint. I hadn't used it in 5 years, and I'm trying to learn it again. So thanks for letting me try to go here this time. All right, I'm going to talk about knee injury. I have about 15 to 20 minutes. This is obviously a very vast topic, but try to cover some highlights of some knee injuries. Football just started last week. We're already seeing our ACL tears coming in, people getting hurt. So just to kind of put it in perspective, I found this study. It was a large high school study done with probably about, I think, 100,000 kids. And of all the high school injuries they saw in sports, 15% were knee injuries. And these are injuries that people went to the doctor for, not just, oh, I hurt my knee on the field. And of that, 12% were ACL tears, 26% were patellar dislocations, 25% were MCL sprains. So, and the highest injury rate was, of course, football, but if you look, the next two big things are girls soccer, girls gymnastics. Girls are definitely more prone for knee injuries than guys are. And girls basketball is very high, but remember, there's only 10 players on the basketball team, so we don't see that percentage that we do with girls soccer, gymnastics, and football. So I'm going to kind of highlight some of these. First, quickly go over knee anatomy. The knee is made up of two major bones, the tibia and femur, and these are the four main ligaments that stabilize the knee. See this pointer? The dreaded ligament tear, the ACL, that's like everybody knows those three letters now, it seems like. You have your PCL, which provides posterior stability, and then the medial ligament, which is called the MCL, which is right along the inside part of the knee, and the LCL. A lot of MCL injuries are seen. The ACL obviously is a dreaded complication, tear, surgery, 6 to 8 months, you're out. And then looking from the top of the knee, the other structures that we commonly see problematic are the meniscus. This is the lateral meniscus, and this is the medial meniscus. Again, these are both C-shaped structures. They're kind of the cushion of the knee. Basically what they do is they increase the surface area of contact. If there's no meniscus, there's point-on-point contact, which results in wear and tear and arthritis down the road. So just kind of, what my goal here is to just tell people, hey, what is a bad knee injury so you can recognize it. You don't have to run to the doctor every time saying, oh, my son got hurt, daughter got hurt. So the first thing is any knee injury, timing is important. The better they're seen, the easier it is to see them, because what happens is as we wait a day or two, their muscles start spasming and they have a more difficult time of assessment. So the best exam sometimes is the trainers. And the great thing about Texas is we have all these trainers at all these high schools, luckily, that are available, and they work hard doing these sports seasons. But a lot of times when I talk to a trainer on the phone, that's the best exam we get. Because by the time they come to clinic, they're swollen, they're stiff, they're guarding. I think like anything in medicine, the biggest thing is listening. A lot of times just listening to the patient will tell you their injury without even touching the patient. So a lot of times it's, hey, how did you get hurt? Where was it? Did you get hit? Was your knee planted? Did it twist? Did it pop? Did you go right back in the game? Well, a lot of times they got hurt, they went right back in the game. That's a good prognostic sign, probably nothing too serious. Then of course, how quickly did you swell? Did you have the audible pop? Those are things. And then of course, the exam part that we do in the clinic is also very critical. To me, the biggest separation between a bad knee injury and not so bad knee injury is what we call an effusion. An effusion is swelling in the knee. To me, when I see a fusion in clinic, that's an automatic probably MRI. This is a concerning ACL tear, patellar dislocation. And the way to look at an effusion is to kind of take pictures here. A lot of people will say, oh, my son or daughter's knee is swollen. Really, the swelling we look at the most is right here. If you look at your own knee when your knee is straight, there's these little pockets that form on this is the kneecap right here. There's little pockets that form on the side of the knee. When those pockets are gone, like for example on this knee, you'll see that pocket's kind of blown up. That's an effusion. That's blood or water in the knee. Similarly, if you're looking from top of the knee, you'll see this little pocket on the inside, and now you look from the top, it's completely gone. That's swelling in the knee that's concerning. Swelling on top of the knee, like you hit your kneecap and you have a little bruise or swollen, that again is concerning, but not as concerning as what we call an effusion. And I'll tell you 90-95% plus of patients that have an ACL tear or a significant knee injury will have an effusion always. So to me as a parent, or hey, my kid got hurt, is it really bad right away, we need to go? I would look at that one finding that I think is observable by the naked eye, even for an untrained eye. Now the big thing is you come to our office, we get the exam, we get the story. A lot of people get upset, why are we getting x-rays? This is a sprain. Well, x-rays tell us a lot. One is we look for fractures, and number two is for growth plates, especially in our younger population. If your growth plates are open, it really changes the way we do things. So I think those are the reasons we get x-rays. CT scan is pretty unusual unless we know you have a fracture. And the most common thing we are ordering is an MRI, of course. This is our favorite treatment, is RICE. Rest, ice, compression, elevation. I get calls all the time at home, just like Dr. Ken calls, my friend so-and-so got hurt, my mom says I hurt my knee. It's always like, do this. They're like, 95% of your problems you fix by doing this. And that's true. A lot of things that we see just need this. They don't need surgery. They don't need MRIs. So when in doubt at home, kids hurting, you rest them, you ice them, compression, elevate, at least start working on that swelling control. So what I want to cover are the most, probably the 5 common knee injuries that we see in clinic that need something done to them. The contusion, I'm just going to go over one slide just to kind of explain to you. A lot of times people panic. It's not something to worry about. And then the other 4 injuries are the more common injuries that we treat and that need to be dealt with. First is a contusion. A lot of times kids will fall directly on their knee. They'll hit their knee, they'll get hit by a helmet, they'll get cleated in their knee. Those typically are not bad injuries. Typically, they'll come with this bruise on the top of their kneecap. Again, remember that pocket I was talking about? You see how the pocket's still maintained? So we know this is probably not something internally that got damaged in the knee. This is an external trauma to the knee. And that's usually a good sign. At the most, sometimes get an x-ray just to make sure they didn't fracture their kneecap. But this is usually localized pain on the kneecap. Their exam is stable. Again, the treatment is ice, rest. A lot of times, a couple weeks are better. The thing you'll find with this injury is people have problem kneeling on it. A lot of times, for 6 to 8 weeks, they'll say, oh, it hurts to kneel on it, and it'll be uncomfortable. Otherwise, they're able to usually get back into the sport really quickly. Sometimes within a couple days, I'll let them go back if I'm comfortable knowing they have no ligament injury. This is probably the most common ligament injury we see in orthopedics. And this is very common with football injuries especially. They get tackled on the side of their knee. Usually the way you get hurt here is your knee gets hit from the outside and the inside part of you the foot goes outwards and it sprains that MCL, which is right on the inside. More common with football, we see it in soccer, all the sports of course. The hallmark of this is, they'll say they got hit from the outside, their knee kind of went outwards. On exam, the one thing I want to mention is this will not typically have an infusion because, again, this is an external knee structure, so we won't see that swollen knee, but they will hurt along the inside part of their knee. There's 3 grades of MCL sprains. There's a grade 1, 2, 3. It's basically on exam how loose they are. So the diagnosis is, like I said, we stress it, and then we can see how much the knee opens. And then usually we feel the MCL on top, which tells us if they hurt or not. And then the key hallmark to me on this one is no effusion. That's a good sign that it's an isolated MCL tear. The only time we get an MRI is if we feel there's an effusion or there's a concomitant injury such as an ACL or something of that nature. Typically in clinic we'll brace them. This is a sleeve brace. I usually just use a sleeve brace with little hinges, metal hinges on the side. If it's a grade 1 where they're really stable, usually I'll let people go back 2, 3, 4, 5 days, a couple weeks in the brace, and they're hopefully back. Grade 2, 3, as they get more severe, obviously longer time out. But again, it does heal on its own. A lot of times we don't even order an MRI for this injury because it's very stable. And like I said, we'll brace them for 2 to 3 weeks, but we'll let them get back, a lot quicker with just an isolated MCL sprain. The other thing we see is meniscus tears. I will tell you, the meniscus tear population to me is typically 40 and above is the much more common. Kids, we see them, but usually it's along with another injury, an ACL or something else that happens. Usually it's going to be a twisting injury. Very few things in orthopedics happen with your knee straight and directly hit. Most things happen because you plant your foot and you get torqued or your knee twists. Usually they'll get a little bit swelling. They'll have pain on the sides of their knee along the joint line, which is kind of right along on this corner and this corner. It's very localized pain, and a lot of times they will complain of locking and catching. Here on this exam, you'll see again, this is the side of the knee, kind of very point tender right in that corner. Not in the front of the knee, more on the side part of the knee. You can see here, this is the inside part of the knee. They're kind of palpating the exam right there. Of course, for the meniscus, you need the MRI. That is the only way to really truly tell if it's a tear. There's many different types of tears. In kids, we're a little bit more aggressive in trying to fix them. As we know, these are very critical. The ones that a lot of parents will say, oh, you can fix every tear. We can't really. The ones that we're able to fix are these, what we call longitudinal tears. You can see how there's this nice line. We can stitch it. When it's kind of a complex tear, it doesn't heal as well. Remember, the meniscus blood supply as you get further in is less. So it's really vascular back here, meaning it heals better back here. As we go to the inside part of the meniscus, there's really no blood supply. So if I were to try to stitch this in surgery, it's going to be back in 3-4 months with a failure, and we're going to have to do surgery again. So again, these are just different type of tear patterns we see with meniscus tear. 95% of the meniscus has to be surgically operated on because they don't heal. This is a nice meniscus under arthroscopy. You'll see this nice smooth C-shaped structure. And then in surgery, you'll see kind of this linear tear right here. That's a tear. A lot of times that tear is fixable because it's a nice linear tear. We can put stitches in it to sew it back down. The other one that we see commonly is kneecap dislocations, more often in women than guys. And a lot of it has to do with ligament laxity. And here you're going to see this kneecap is centered here, but you can see how unstable or loose that kneecap is as it's being pushed outwards. Usually, again, a twisting injury. Sometimes the MCL can tear with it because it's on the inside part of the knee. 99% of kneecap dislocations occur with the kneecap going outwards. I've rarely ever seen one go inside. So the big thing on evaluation is to know if it's their first time or this has happened multiple times. They'll usually tell you that, hey, we popped the kneecap back in, kind of push it back in. They'll present with a very large effusion, a lot of blood in the knee. In fact, I saw a girl yesterday that popped her kneecap out. I took off about 120 cc's of blood, which is a lot of blood. I mean, her kneecap popped out. It's just the trauma of tearing the tissue and the bone bruising that goes with it. They'll be very guarded with the, moving the patella, and they'll typically not really move the knee at all. They'll be pretty stiff. If it's their first time that they popped out, very conserved treatment. Get the swelling out, get the knee moving. A lot of times we'll give them a special brace. It's called a Lyle J brace. It has a little J to hold the kneecap in, get their quad strong, get them trained again, and once they're kind of running, typically the first time I wait 3-4 weeks and we'll get them back to sports and let them go back full activity at it. Now, we have obviously a large population of people who have recurrent dislocations, then if that does become a surgical issue. Then The girl I saw yesterday, on the x-ray, I could see a little loose piece of bone, so we did get an MRI because we're worried about a loose piece. But typically, the first time they're dislocating, we're not, again, getting an MRI. As physicians, we're trying to be a little conservative with testing. It costs patients money, it costs the system money. So some parents want an MRI every time, but we use our clinical judgment and recommend it if it's truly needed. So I'm going to spend five minutes on the ACL. This is the tear that everybody talks about and everybody knows about. You see them in the paper every day. ACL tears, a lot of people think that ACL tears only occur when you get hit. No, a lot of the ACL tears we see occur with a non-contact injury. For example, I had a football player yesterday, he said he was going down the field, he stopped, he planted, knee popped, gave out, and tore his ACL. There was absolutely no one within 10 feet of him. It was a non-contact injury. I'm going to show you a contact injury and a non-contact injury on an ACL. This is Sam Bradford. As you guys know, he tore his, is it not playing? Let me go over here. I'm just going to show you, it's kind of a cool video, I thought. What do I do here? Lauren?
I'm glad you set the bar for me. That's good.
Well, I thought we should have got to work, and for some reason he plays video. There's no fun without seeing a nasty knee injury on orthopedics. You can play on that. So Sam Bradford, just so you guys know, about 2 years ago he tore his ACL, he had it fixed, and he re-tore it last year. The reason I bring that up is, unfortunately, ACLs, there is a history, a lot of times people have surgery, they're like, never going to tear it again, but it happens. Even in the greatest athletes like Sam Bradford, who's making $10 million a year, $15 million, and it's not going to do it. How would you do it? Okay.
Try to hit where the hand seconds.
Oh, on this computer? Oh, and no, then maybe it'll work on my top. Oh, no. Can you go back to my top? We'll work on my top. Yeah. Okay. So if you look, pay attention to his left knee. It's going to be fast motion, it'll go slow. Look at there and do it again in slow motion. Right? His left knee literally 90 degree. He tore his ACL, MCL. Subsequently, like I said, he had surgery and then, I think first or second game back, re-tore it. So point of that is two things. One is obviously high velocity injuries like football create this. And then also, I do want to point out, I wish as a surgeon that I could say I'm 100%. But I think the public needs to realize it's one of those injuries that happen, and if you put yourself at risk, it's going to happen. It can happen again. And so let me see here. Where did that other? I'm gonna figure this out. Here. Sorry. And this is a gymnast. Just again to point out the non-contact. She's not around anybody. You're going to see her left knee again. Watch in slow motion. Again, this is not like a football injury, this is a gymnast. And if you look, that knee right there. So again, ACLs can happen with contact or without contact. Typically they will say, oh, we heard a pop. Again, not all the time. And then a lot of times, pretty immediately, they will swell up. That effusion I was talking about will occur. We have a couple tests we do in clinic to test the stability of the knee. Again, we're good, but not great. Sometimes there are certain things that restricted the patient's spasming, he's regarding, that will restrict that. We do get x-rays always, again, because we want to look at the growth plates and also to see if they have any kind of a fracture. And if we doubt an ACL tear, then of course the MRI is the way to confirm it. Here's an MRI to show you. This is a side view of the knee. You can see a normal ACL is nice and black. It's connected from the femur bone to the tibia bone. And if you look here, that nice straight structure is it's kind of all grayed and kind of bulbous looking. and that's a normal ACL and a torn ACL. So the MRI is, I would say, very, very accurate to help us diagnose it. I think ACLs are in a young active population like we have here is surgical. Now there are cases where the patient's older that we would maybe, if they want to go away with it, they're going to play soccer, basketball, football, you got to fix it. With ACL surgery, there's different graft choices you can use. You can use a patellar tendon, which is we take part of the kneecap tendon and the part of bone and do surgery, make a new ACL. You can do their hamstrings, or you can use cadaver graft. In my practice, and everybody has their own preference, I use patellar tendon on my young population, but if they have open growth plates and there's reason to preclude it, then we use hamstring or patient choice. I did a volleyball player on Wednesday. She kneels a lot on the ground, her knee hits the ground. Well, with patellar tendon, she's going to have a lot more pain, so we did a hamstring. In my young patients, I will not use cadaver graft. The only time I use cadaver graft is when we have a hamstring and we have to make it a little bigger because they have small hamstrings. And I'm going to show you a study here in a second that explains why cadaver graft in a young patient is very high risk. My treatment is return to play is usually 7 to 9 months, sometimes 6 months if they really rehab well. They're limited really by the rehab part of the quadriceps, and that's really where they're spending a lot of time rehabbing and spending time with the therapist getting it stronger. This is a group. It's called the MOON Group. It's called Multi-Center Orthopedic Outcomes Network. This is a group of about 20 physicians in the U.S. They're following all their ACL reconstructions. They're a younger population, about 27, anywhere from 12 to 40 years of age. They've done 2,700, and these are the 2-year outcomes of this 20 surgeon population. So 4.4% re-tear rate on the knee they had operated, and 3.5% on the opposite knee. So some studies will say there's a twice as likelihood of tearing your other knee than the knee you had operated. So the big thing is, and Brad is going to talk in a few minutes, is prevention also. So these kids tear their ACL, yeah, we get them great. We got to protect them from happening to the same knee or even the opposite knee. So that's the big thing with ACLs. A lot of times we're seeing more people tear their other knee than the knee we operate on. This is a big factor here, I think. Failure of allograft was 5.2 times higher. So I think any of your kids have an ACL, if we're not treating it, whoever treats it, I think if you get a surgeon that say, hey, we're going to throw an allograft in there, they're going to do great, they're going to hurt less, I think you tell them right away, no. And that there are doctors around town, and I know there's some that we see people with multiple opinions and all that, they're saying, oh, do allograft, they won't hurt, they'll be back in 4 months. But I think right there, that's your number. 5 times higher failure rate in a young patient. That's something that you don't want to do in a young patient. So again, I will not do allograft in anybody less than 30, 35, unless there's some reason they have to have a revision surgery, then a lot of times we will use allograft. But for the primary ACL, we won't do allograft. Patellar tendon and hamstring grafts are equal. You'll go to some doctors who will tell you patellar tendon is a gold standard, it's the best way to go, but I think this study proves that they're both equal, and I think whatever the surgeon is comfortable using, or however they like to operate, is probably fair. And then the highest risk factors are younger age, higher activity level, and allograft. And in my opinion, females. They didn't point that out in the study, but I think females are at higher risk of tearing it, just the way they're built, muscle control issues. So that's it. So any questions, or sorry, I was trying to cover a vast topic in a quick time, but.
I have one question, I guess that's more of a comment. We're seeing for a while in the NFL, all the linemen were starting to work prophylactic MCL braces, trickle down into the college. Now it's trickling down into the high schools. Are you seeing that? Is that your
Yeah, I think what happens is the data again. And I wouldn't want to lie by saying that, but even on the ACL tears, I give all my patients an ACL brace for the first 6 months to protect it. But it's been shown even in studies that the ACL brace doesn't necessarily protect you against an ACL re-tear. But I think with linemen in certain positions, it probably does help them. And I think, especially linemen, they're moving more back and sideways. I think you get a running back in a brace, I think it will never happen. I think it does restrict them. But I do think for linemen and stuff, I'm not sure if there's data out there that really has been studied that says, oh, okay, these guys are having 20% less MCL tears, ACL tears. But I do think that that's being used. And I think it makes sense for those positions to work. Yeah.
Can you comment on the risk factors for any of these that long-term would result in a total knee replacement?
Well, I think clearly the data on ACLs is there's lots of studies out there that show once you've torn your ACLs 15, 20 years out, the risk of arthritic knee, total knee is out there. I mean, we see patients, I'm sure Jeff does, that are 40, 45 years old, they're getting ACLs done 20, 25 years ago, they're coming in with arthritic knees. Now, is that a function of, there's a lot of factors. I guess, if you lost a lot of meniscus at your initial surgery, that would cause it. I feel like this ACL that was done 20 years ago was not anatomic, and the ACL that's being done 20 years later is more anatomic. So I think that's a big deal, and we'll see 20 years from now, I might be saying the same thing on my own patients that I'm going to see back, but I think some things were done. I think, and the trauma of tearing your ACL, a lot of times when we get into the cartilage looks good, but there's a lot of inherent damage that's been done that shows its face years in the process. Kind of like your, the head injury. You get hit, but 20 years later, juniors say, oh, all these guys are getting CTE. I think similarly with the knee, that inherent buildup of cartilage and internal damage shows its face years later. So I think tearing your ACL at any point is a bad prognosis sign for arthritis. Okay, thank you.
One other.
Can I have one? I'm sorry, I know I'm on hospital questions. Can you comment, and I know I'm going to embarrass myself really bad, can you comment on the super loop stuff you guys are using in the knee? The DW40 of orthopedic.
All right, well, it's called viscous supplementation or hyaluronic acid. People with arthritis were injecting this hyaluronic acid. They're weekly injections. My take and Jeff's take might be different, but the data, I do evidence-based medicine. I feel strongly in that, so I try to research and prove to my patients that that's going to help. There is not data to support the use of it. There is no study that says that, okay, you using this is going to help. But patients feel better, so we utilize it. Because if you don't use that, it's a total knee. So a lot of times, but the way it works, at least my view, is a lot of people read the Dallas Morning News and said that it builds cushion and it doesn't do any of that. Basically, it's a pain reliever, and the thought is a hyaluronic acid binds to cytokines and all these different things in the knee, and it helps pain. But it works for some, it doesn't work for others. Is that your...
Yeah, I think that's exactly right, Zon. Our academy kind of is kind of talking on one hand and asking the other. Our academy, he's exactly right. There's not any true evidence-based literature that says viscous supplementation works. However, they are now telling us, okay, you have to try all these things before you definitively do a knee replacement. Same thing with cortisone injections. A lot of those tests are showing us not really helpful in preventing knee replacements, but they're a pain reliever. So I think he's exactly right. The literature doesn't support it, but community practice does.
Yeah, there's one more thing. Recently, a lot of people are talking about stem cells, and I don't know if you guys have seen all that craze of stem cells. And in Europe, it's really big. It hasn't become so big in the USA because insurance isn't paid for it. But I actually went and visited. I did a fellowship with Dr. Andrews, who's in Birmingham, big sports guy. I visited their facility last week when I was on vacation, and they're doing it a lot. They're finding people are getting a lot of subjective pain relief. Again, the data is not there. People think the stem cells are going to go and become cartilage cells and grow. It doesn't happen, but they've done 100, 200 shots in arthritic knees, and they found people subjectively feel good. So something that I've talked to some of the guys, and we maybe will start. The problem is the insurance isn't paying. It's about $3,000 to $4,000 for a shot. So the cost is immense, and so patients want to experiment with it. It's no harm, but it is still an expensive procedure. We take blood from the hip here, and we inject it into the knee. So it's something that's out there. I don't think the data supports it, but again, people will do anything not to have a total knee a lot of times. So you got to provide them everything that's possible to help them with that.
Thank you, Dr. Singh.
Yeah.
All right. We've had a lot of really good discussion. We do have one more lecture. Brad McClatchy helps run our physical therapy department upstairs. He's a great speaker as well. All his bio, and I'm not going to read it, is in your handout. I will tell you that we have been having fun and talking about these, and our talks have gone over a little bit. The plan was after Brad's lecture was to have a group of other professionals that are here with us kind of have a question and answer session. And out of respect for y'all, if you're running out of time, won't hurt our feelings if you need to leave. But our plan right now is we'll have Brad's talk and kind of stand up and stretch a little bit, and then instead of having the panelists come up and sit here and talk, we've got a small enough audience. I'll pass the microphone around. We can talk about things. Seeing that we've got Brad McClatchy talk about a very pertinent subject, especially with female athletes, is preventing ACL injuries, which goes hand in hand with what Dr. Single was talking about. because he was right, the females do have a higher increased risk of injury and re-injury of ACLs. Brad? Okay, sure.
Lauren, I need you again.
Yes, you're already up.
All right, we appreciate everybody being here today. Show of hand, are there still some athletic trainers that are here? Anybody? When we're discussing ACL prevention, again, knowing there has to be some research that actually supports this, so that's what I'm going to touch on quickly. As Dr. Singhal mentioned, he talked about how ACL injuries can be a contact or non-contact injury. Anybody here have an idea of what % of ACL injuries are truly non-contact? There's no blow or trauma like that football player talks about. And at least can get Dr. Wilkowski or Dr. Littlemore to answer that one, I hope. 70% of ACL injuries are non-contact injuries, 65 to 70%. So that's a large problem that we hope that we can find something to do to address. I'm going to show you a very quick video here, potentially. No, it doesn't. Just click on that spot. Yeah, it's just going to be more the mechanism of the injury that you're going to see here. Non-contact, this is probably 15 years ago, Jason Sehorn returning a punt to the Giants, planted his right leg, and there it went. And so it's the translation of the tibia, as we've got a fixed foot, the rotational components, creating a little bit of that valgus stress, and the ligaments, the thing that goes. And then Dr. Singhal talked about how you'll see the excessive swelling will develop afterwards, and there's a diffusion. So, very good. All right, so we've got the sharp acceleration, the lateral pivoting, the joint going into a valgus load with external rotation, and sometimes an extension load that follows that. The result of these various forces results in the extension combination, the tibial rotation, and then the ACL being the weak link it's going to give on you. So we said non-contact injuries, 65 to 70%. As Dr. Cantrell mentioned, 4 to 6 times more likely to occur in females and males. So almost every bit of literature out there focuses on studies of the females. I found one on males in the course of our review. Dr. Cantrell had a great slide earlier just talking about Title IX and the advent of more females participating in sports. We see it, not only the year-round sports competition, the boys now, but the females too. And if we don't have the neuromuscular capabilities of controlling these forces, then you start to see the increased risk of injuries. Surgical and rehab for an ACL injury, $18,000 to $25,000 on average. Results in lost playing time, as Dr. Singhal said, out for 6 to 8 to 10 months in general. So then reduced academic capabilities, scholarship opportunities, more of the socioeconomic things that go along with that. Long-term disability, we talked about the greater risk of osteoarthritis that can develop. And many of the surgeons will tell you that's because of the bone bruise and the injury to the cartilage. So that trauma can affect them down the road. We've really been collecting data here for about 20 years on ACL prevention. Part of that, I think, is the fact that the orthopedists themselves have become a lot more skilled at doing the ACL surgeries in the last 20 years. And so now we're trying to find out, since there's so many of these athletes being injured, how can we start to prevent this? Example of a basic study they took American Journal of Sports Medicine in 2009. A group of basketball players, half in experimental, half in the training group, 8-week program. And the results, what they were looking at is they studied these athletes with biomechanical analysis, as you would see where they do the studies with the cameras to videograph all the different things that are changing. So the experimental group that did their 8 weeks of pre-training had higher knee flexion angles, meaning as the person lands from a jump phase, they've got more knee flexion, which reduces the amount of extension. Greater inner knee distance, what we mean by that is we're not seeing this knock-knee valgus presentation, so their knees are farther apart. A greater instance of utilizing the hamstrings, the posterior portion of the muscle groups to reduce the quadricep load, so there's less knee extension torque. Greater knee abduction. If the hip abductors are working well, the knee will adduct less. And then the general conclusion was that the injury prevention program helped. This is more of a kind of a landmark study that was done in 2002 was when they collected all this data. It appeared in the American Journal of Sports Medicine here in 2008. But basically, they got 61 NCAA Division I programs to participate in the study. So they had a large group of athletes, over 1,400, 583 in the experimental group. And they were doing some neuromuscular and proprioceptive training. Now, you may say, what is neuromuscular training mean? Well, any of the females in the room have had a child. You've done neuromuscular training postpartum with your Kegel exercises. It is simply asking you to do some muscular component to a movement that enhances the body's availability to stabilize the structure and more effectively recruit the muscles in this activity. So these individuals did this training program, and the findings were pretty major. It said ACL injury rate among the athletes who did the intervention, 1.7 times less likely to suffer an ACL injury that year, and the non-contact ACL injury rate, 3.3 times less. Systematic reviews along the lines, again, should support this. Risk of ACL rupture almost 2 times higher in female athletes who did not participate in these types of programs, and soccer athletes 2.6 times higher. And I could bore you to death with studies, but Dr. Singhal mentioned something to me. We do start to have some almost preventative programs out there nowadays, like you see in personal training. And what these professionals are touting is that they can teach these athletes some specific strategies to help reduce their risk. And I do believe that's the case. We just don't know how long they need to work with them, how many times they need to do this practice. This study combined, a meta-analysis studied 6 different studies, anywhere from 18 to 108 sessions of training, 10 to 75 minutes in length, and anywhere from 6 to 41 weeks. We're going to go over here what these neuromuscular training components are, but we just simply don't know the amount that needs to be applied to make it safer. And this group study, again, had a large sample rate, so that was very vital for at least supporting some of this information for us. These participants, through games of practices throughout the course of a whole season, it came up to over 573 different total exposures, and so the evidence was strongly there that there was a reduced risk, as we said, almost a 2 to 3 time reduced risk in injuries. What I wanted to mention to the athletic trainers or anybody who's kind of evaluating these athletes, and I think about the orthopedists when you guys do some of the screenings pre-season for these athletes, is we can't control a lot for some of the intrinsic factors, the way a person's built, decreased femoral notch, how large the ligament is, some of the things that just genetically are there. But you may be able to see some of these things when we're evaluating these athletes. This young lady is a middle school student who tore her ACL in soccer. She's now 4 months post-op and released to at least start straight ahead running. And if you look at there, we're looking at her left side. The left knee was the one that was the surgical knee, and you might think she's got a little bit of a flexion contraction. The knee is still bent. It's actually not. She's got full extension of her left knee. But her right knee goes into about 15-degree genu recurvatum hyperextension. So there's where we say, if we look at that, we do have a little bit of increased risk. When she's planting her leg, she's got the tendency to be able to genetically go into a hyperextended position. If we look at her from the front, genu valgus position of the knees can either result from weak hip muscles or just from the genetic gifts that they have. Pes planus foot. Dr. Willenborg might say, well, let's try to support that foot a little bit with some arch support so when she's planting on the ground, we don't have so much pronation of the foot. So all those strategies that we're going to try to employ may be more successful if we can at least pick what athletes might be more susceptible to this type of injury. 4 common factors that occur when an ACL non-contact injury happens. As we saw in these videos, if you've ever suffered an ACL injury, when you watch these videos, you feel kind of sick to your stomach. You feel like you're watching train wrecks over and over. The knee buckles inward, the leg is locked, sometimes relatively straight. All the body weight is on one extremity. And lots of times their center of gravity, so they're outside their base of support, so they're leaning to the left or right with their trunk and not able to keep their center of mass right over their support.
What we're finding in many of these athletes who are more susceptible is that they employ 4 different strategies when they're moving, and these strategies are what we call necessarily poor strategies of handling performance. So if you're ligament dominant, what that means is if you're doing activities and you don't have enough hip support or muscle strength to control your movement, that knee ends up in that valgus position. So there's not enough sufficient stabilizing to reduce the risk on the ligament. Walking, we talked about, there could be just 2 to 3 times your body mass impact on the leg and on these ligaments. But in landing, cutting, running, jumping sports, 5 to 7 times the load on that ligament. Quadricep dominance, I'm going to show you some pictures here in the future that shows why we feel that female athletes might be more prone or susceptible to these injuries. They're tending to utilize the quadriceps as a stabilizing force when they land it, and that's not the most valid or appropriate way to stabilize a knee joint. We need the larger muscle groups from the posterior hips and hamstrings to be stabilizers. When this is the case, the quadriceps are the stabilizer, the shear of the tibia will be more pronounced. And then leg dominance, if we see an athlete who maybe plants one leg all the time, say the gymnast we saw there taking off on the platform, they may always jump or lead with their left leg. Sometimes you'll tend to see that leg will have better muscle recruitment, strength, and flexibility. And then trunk and core dominance, meaning when they do land or plant, if they don't have the central trunk control to keep their mass over the top of their hips and leg within the center of gravity, then they're at more risk. And we'll see this sometimes in athletes who are growing quickly. We talk about females, but you see it also in males. These guys are growing sometimes 4 to 6 inches in a year. With the females, what we'll see is if they have a growth spurt, not only are they developing height-wise, but maturity-wise. And so now you're going to see larger muscle or larger mass trunk, larger chest girth. They're going to have a lot harder time controlling their center of mass, which is brand new to them now. We're going to do some interventions or show you some things that you might do from a preventative setting on the field, in the training room, and here in therapy to address this activity. Our ultimate goal is try to recruit the hip hamstring muscles more so. They have a lot more attachments to the knee. They'll help control femoral rotation inward and help reduce hyperextension of the knee or the tibial translation forward. All right, I employed Jody here to come help me just a little bit. And if you'll give us a second to bring our toys, as therapists we have to have toys. So you may stand if you want to see this. I'm going to jump ahead to a couple of pictures that are going to give you an idea of what we're trying to do. The one study that I focused on here talked about what happens when we're doing some of these different activities. I'm sorry, folks. Right here. If you can see a little bit of this, as this lady on the left here lands, what we're trying to attempt to instill in these athletes is the ability to control their momentum. And many times if they don't possess the neuromuscular capabilities and strength to do that, they're putting themselves at risk.
So Jody, I'm going to have you do just a squat jump for me. What we want to see is when they land, their feet land in the same point every time. Shoulder width apart, hip width apart. Do a couple for me, Jody, just to see if you get tired. You don't want to see their knees buckle inward. You'd like to see that they have control, and when they land, they come into a squat, not into this position where you see their knees come out over the front of their toes. We're going to show you a couple movements. What you're really trying to recruit in these people is their ability to address or access their posterior chain, say their hamstrings, their hip muscles, because they help so much with movement. So I'm going to have Jody here. Can you do a bridge on the ball for me? You can start with some of the basic simple exercises, which are going to be supine. They can bridge off the floor. They can bridge off the ball. You can start to be creative, as Carolyn would know. You can do 3,000 different core exercises. But what you want to basically do is get them to start to utilize these muscles. This is no different than if you and I were trying to learn to write with our non-dominant hand. It can be done. You have the physical capabilities, but you haven't done enough motor training with this over time to make these muscles engage quickly. Now do a hamstring curl as you do that. So a tuck and pull in. In the athletic training environment, we'd also obviously engage them or try to teach proper technique with their squats, their lunges. Let me have you go ahead and do a squat for me, please. One of the techniques you'd want to try to teach them is show me a core form where your knees come way out over your toes. There you go. So now they're going to have a lot more stress on the knee joint here in this position. Now see if you can correct that form for me. And sit back. And one of the techniques you'll try to teach these patients or athletes is they won't know how to do this. It feels very foreign to them to engage these muscles. So you may have to have them start from a chair, sit back so they've got something to start with, so that as they sit, they don't feel like they're going to fall. Maybe you have to prop their heels up on something, but you've got to get them to engage back so that their hips are, their knees don't come out over their toes. All right, Jody, let's do a couple real simple stabilization exercises. So we said we want to be able to recruit, let's go around your trunk. We want to be able to recruit the posterior hip muscles. We also want them to have the ability to stabilize themselves against force. So go into a lunge for me. Now we said non-contact injuries are what we're trying to prevent, but what about the simple little jostling movements that occur in sports where they're going to find their center of gravity challenged just ever so slightly? Can they maintain their force there? Working them from all directions, maintaining that proper form. Drop their hips down and then weight shouldn't come out of their knees. And they're going to get fatigued and tired, but you can try to add perturbations to see if they can stabilize themselves. So that part, the creativity part, I'll let you look up yourself or visit with your favorite personal trainer to try to find that. We're going to go to one functional strategy here that they did, and that was called a tuck jump test. There's actually a form up there that allows you to watch the athletes do this test and grade them to see how well they perform. So it's a real quick way to assess their risk. When you do a tuck jump test, you're going for 10 seconds. So Jody, I enlisted you today to try to demonstrate this 10-second tuck jump test. Now their goal here is they're going to try to elevate their knees up high. Go ahead for me. In fact, I'll have you see if you can come get this pull up better, because it would be nice if I could show you the videos. Try it. You got 10 seconds. That was just one. Go for 10 seconds. Go right ahead. Good. And stop. Good. All right, so what we're grading there, we're trying to see how their performance degrades over the course of 10 seconds. Are they landing with their feet in the same spot every time? Are they off to the side with their center of gravity? Do they have the ability to, when they hit the ground, to bound back up again? And one of the things you talked about with plyometrics, which is what Jody was just performing, is we need to be able to demonstrate that that athlete can actually squat their body weight before you throw them into these plyometric environments, because otherwise they're not going to have the strength to begin to do these activities in the first place. That's fine. What it shows here is how you're going to grade their performance in this tuck jump test. Ligament dominance would be if they land with those knees in valgus. Quadricep dominance is if they land with their weight out over the front of their toes. There you go. Thank you, sir. Go ahead, go down, yeah. Single leg dominance, that's if they're leaving in the jump and they're landing on one leg each time instead of landing on both when they come down. Trunk dominance, meaning this individual is obviously way outside of her base of support, center of gravity, so she's not going to be able to compensate for the mechanism that's going to occur. And then the last slide just simply shows that's what good form should look like. How many athletes do you know, we put them through a screening test, they're not going to look like that. Probably about 5% of them can do a jump movement that well. But that's what you're shooting for, their ability to control forces and land equally there. All right. So again, there is a lot of evidence out there that at least if we can employ these neuromuscular strategies, we can assist in reducing the ACL injury component. As Dr. Singhal mentioned, they're at risk, and if they've had an ACL tear, they're 4 times more likely to suffer a tear either in that knee or another knee as well. So we'd like to minimize that if we can. We know that these control programs, if we really emphasize trunk and core stability, can help reduce the risk, and we have to have multiple exercise interventions. What I mean by that is if you're training a volleyball player, a lot of jump tests, a lot of things like that, because that's going to be sport specific to their activity. If you're training that tennis player or soccer player where they're changing direction more, then your drills need to focus on being specific to that activity they're doing. We know that the emphasis on this training works. We don't have a great, clear understanding on how much we need. Obviously, that may be sport specific to the individual as well. But we simply know we can at least start to engage these activities and make, hopefully reduce the risk of these injuries long term. Any questions?
I have one. How many of these programs are in existence and are they used around the area, you know?
You know, probably, I would say some of the athletes, I'm going to ask, I've got a gentleman here who's got kids who are athletes utilizing these strategies. When you are being approached by these individuals who are coaching these programs, did you find a lot of them in the area, or did you just find the one?
Just the one through recommendation, but I
Yeah.
hadn't heard of it.
We've got some athletes here in the Flower Mountain community. Use a gentleman in South Lake that's doing a lot of this training. And basically his background is exercise physiology. He's got a master's, and he's kind of personal training to the next level. He's taking these athletes who may be susceptible or participate in sports and trying to get them to utilize some of these strategies. So I like the concept because you don't want just a mill out there. You want to be able to, you know, you've got these pitching coaches, these hitting coaches, everything working specifically with what we're trying to prevent or improve in these athletes. And so I just know one gentleman now in the area, but if you get on the internet, you'll find several touting this type of strategy, which I like. I think it's a good.
But I think the problem is, you know, for me, we're doing these preventions once they carry. Right. The question is, how do you institute these programs? I mean, these kids are going to play 4 hours a day. They spend 10 minutes doing some of these exercises. Is it going to, you know, help them?
Yeah.
And it's kind of like with pitchers. You know, we have pitch count, or at least some of the guys that come over with pitch count. I think with ACL injury, I mean, everybody's playing so much. I think it's not. I'm seeing a lot of tears much younger now, and I think it's purely because of exposure, not because of, you know, I mean, they're playing a lot. So you're going to play all year versus 3 months a year, or 4 months when I was growing up, you're 3 times as likely to tear your ACL now. So I think the question is, as physicians or as therapists, at what point can we get something instituted in the school with trainers and everybody to make them do it? But the hardest thing we have, and you know, as a therapist, is having these kids do their therapy after surgery. I mean, how do you get them to do a prevention thing if they can't do their therapy after surgery? And I was a kid once, I couldn't do it. I mean, you know, and so I don't know at what point we can get that prevention program started before they tear it, rather than once they tear it.
Yeah, and the other challenge, like you said, is these kids are playing year round, but they're playing year round at earlier ages before they're